Thank you. I hope that you also don't have any problems with the translation into Turkish, and that I speaking so balanced, so you can also understand. So I'm going to share the next presentation. Here it is. About the first-line treatment in mixed urinary incontinence when planned before any type of surgery. If we have a look at the EU guidelines and other papers talking about the evaluation and treatment of mixed urinary incontinence, we always see that clinicians are encouraged to begin with the most bothersome component of the women's symptoms spectrum, in this mixed urinary incontinence. And the goals are to correct voiding patterns, to improve the ability to suppress urge in these patients, and also increase bladder capacity and to improve or gain continence, ideally. We have several conservative treatment options and also pharmacological treatments in this first-line treatment. And I want to discuss with you some studies just giving this evidence. In every patient with mixed urinary incontinence, it doesn't matter if they have a balanced mixed or predominant stress or urge incontinence, we can have some general treatments that we can begin with them, some general considerations. In this paper, we'll present it as a guideline of the Canadian Urological Association. We see that there are some type of managements that can improve patients. And I want to discuss the evidence for each one, only to discuss some points. About the weight loss, we've got a recent review, a meta-analysis performed, and when compared with normal body mass index, they found that overweight women had 1/3 of increased risk of urinary incontinence. And when obesity is present, this risk was doubled. So it is quite common to ask patients with obesity or overweight to lose weight. There's no statistical difference in the risk in any of the three subtypes of urinary incontinence. So it is also effective in patients with mixed urinary incontinence, as well as in stress and urge purely. This is also a nice report of the ICI Research Society, published some years ago, but that is quite interesting because they mixed a review of the literature with also expert opinion. And they state that fluid manipulation is important because you can reach a reduction in daily voided volume, voided frequency, urgency, and also incontinence episodes frequency. On the effect of caffeine consumption, it's not very clear because in the studies we can find different concentrations of caffeine, and also we can have some influence of caffeine levels found in colas or other carbohydrate drinks or chocolate that can have an impact in the caffeine concentration. So that could be the reason for not having the definite results about the effect of caffeine. About behavior modifications, it had been shown that it's effective in both stress and urge urinary incontinence, and it can be also more effective than pharmacological treatment in each types of incontinence, then these subtypes. So we can also extrapolate that it can be useful in mixed urinary incontinence. About pelvic floor muscle training alone, we found in this Cochrane library review that for women with any type of urinary incontinence, patients were 5 times more likely to report cure when they performed pelvic floor muscle training. And also there's a reduction in the number of leakage episodes, the quantity of leakage on pad tests, and also the symptoms on any symptoms questionnaires. What about specific measures in urge predominant mixed urinary incontinence? Which tools do we have? For postmenopausal women, we can have vaginal estrogen, and also we have different types of oral or transdermal medications. For vaginal estrogen, we know from this Cochrane review that we can find a decrease in the bladder diary of the number of voids and also of urgency episodes. But this effect is only found in patients with vaginal estrogen therapy, with local therapy, because if we give the estrogen systemically, it can even worsen the incontinence symptoms of the women. So be careful with that. You can also find some studies talking about asfenifin use. And besides the improvement in sexual symptoms and urinary incontinence incidence in this menopause syndrome of urogenital syndrome, you can also find improvement in dysuria, frequency and urgency, a decrease in the mean number of voids, the urgency events, nocturia episodes, and any type of incontinence episode, and very important, an improvement in patients' quality of life. About anticholinergics, there's some studies, not many studies, focusing specifically on patients with mixed urinary incontinence. Most information can be taken from studies performed in patients with urge urinary incontinence. But as we have said before, in my presentation and also in Stefania's presentation, our patients with mixed urinary incontinence have a worse presentation and they've got a worse quality of life. So it is important to show these studies focused specifically in patients with mixed urinary incontinence. And we see, for example, with propiberine, that this medication was able to reduce both episodes of urge and stress urinary incontinence. And these patients had a significant reduction in the overactive bladder symptom scores and in the general score of the ICQ urinary incontinence short form questionnaire. For sulfasalazine, we see that they also had, in this study, they had a statistically significant reduction in voiding frequency and episodes of incontinence and urgency when we compare it with a placebo population. And patients had a sustained improvement in quality of life. In patients treated with tolterodine, they had a decrease in weekly urge incontinence episodes, urgency episodes per day, and voided volume per micturition. After 8 weeks of treatment, these patients had nearly 2 times a greater likelihood of an improved bladder condition compared with placebo. So also quality of life was improved. I also found this study published this year on the efficacy of mirabegron in patients with overactive bladder with period urgency incontinence or mixed urinary incontinence. And it's a post hoc analysis of 2 randomized placebo-controlled trials. They showed that their primary endpoint, that it was the change from baseline to the end of treatment after 12 weeks in the mean number of micturitions, was achieved. They also wanted to check if there was any influence in the mean number of urgency episodes or urge incontinence, the voided volume, or the number of nocturia episodes. And they found that they didn't reach significance in the change in urgency episodes, but mirabegron was effective in the reduction of incontinence episodes per day, in the improvement of the mean voided volume per micturition, and also a decrease in nocturia episodes. They also had a look at the change in the King's Health Questionnaire and a quality of life, and they also found significant differences in all the aspects of this questionnaire. We also have, for urge urinary incontinence, other non-invasive therapies that can be used, like tibial nerve stimulation. And I want to show you this beautiful study performed by a group of rehabilitation meds and physiotherapists with a group of patients that underwent 12 patients pelvic floor muscle training alone, and another group of 12 patients with pelvic floor muscle training and tibial nerve, transcutaneous tibial nerve stimulation. After 16 sessions, they evaluated patients with a bilateral manometry and questionnaires, but also 1 month after the end of the intervention, they performed again these questionnaires. What they found is, and they had a look at the ICQ short form with general information about incontinence, but also they had a look at the specific questionnaire for overactive bladder symptoms. And what they concluded is that the results showed weak evidence that the tibial nerve stimulation in combination with the pelvic floor muscle training can be used to treat mixed urinary incontinence, although the satisfaction was good with both. And I would suggest to change these conclusions, because what I see in this study is that in patients with mixed urinary incontinence, the overactive bladder component improves more when the transcutaneous tibial nerve stimulation is added to the pelvic floor muscle training, and that this effect is maintained even 1 month after the end of the intervention. Although there are no differences in the global ICQ score or in the vaginal manometry. So it could be an option in patients with urge predominant mixed urinary incontinence. What about patients with stress predominant? We can begin with the general recommendations we have said before, and also with pharmacological treatment. I put here a question mark because in Spain we don't have any medication approved by our drug agency for the treatment of stress predominant or stress urinary incontinence. I don't know which is the situation in Turkey. But for example, we don't use duloxetine for stress urinary incontinence. We only use it for depression. But I show you this study, which wanted to differentiate between patients with balanced mixed urinary incontinence or with predominant stress or urge urinary incontinence. And they got these results where they saw that in general, there was a significant difference in the decrease of both episodes in stress, in the episodes of both stress and urge urinary incontinence. But also they had a look of in the subtypes of this mixed urinary incontinence, and what they found is that the duloxetine could decrease the incontinence episodes frequency, and it was significantly greater for patients with stress predominant mixed urinary incontinence, and for those patients who had urge predominant urinary incontinence with the Trousseau overactivity shown in the urodynamic study. And they apologized because the balanced mixed urinary incontinence group was so small that they couldn't have significant results for this reason. There's also, sorry, I'll drink a bit of water. This is also a very recent study exploring the use of lithoxetine for treating urinary incontinence. They included patients with urinary incontinence for at least 3 consecutive months, and they had to have more than 7 incontinence events per week. And what they found is that there was a high placebo response that precluded having any significant results. But they had a good clinical safety profile when using the dose titration to detoxetin 30 milligrams, that there was not any influence on psychiatric disorders. They got a reduction of 2 incontinence episodes per day, and that the effect of letosetin was clinically meaningful compared to placebo in patients with more than 5 episodes per day of urge urinary incontinence. And also, I want to show you some future perspectives on these patients. At the moment, we don't have many information, but this group has already published an association with mirabegron and duloxetine in combination for patients with mixed urinary incontinence, and they have shown a statistically significant improvement both in ICQ and OAB symptoms score, and also a reduction in the daily pads. They had patients with both urge predominant and stress predominant mixed urinary incontinence. And also there are some studies trying to find out if we can have other medications in the market, like a new noradrenaline reuptake inhibitor that is supposed to increase basal urethral pressures and liquid pressures. But now, at this moment in the study, there was not a significant effect, but this is only a early phase 2 trial. So we need more information and more greater studies to find out. It is a safe medication, but at the moment they haven't found the ideal dose to treat to find any result. So let's see. So I want to finish with this slide, try to summarize what we have said. It is again from this paper of the Canadian Urological Association journal, where we can see that stress predominant incontinence, we need to have some general measures before considering surgery. In patients with urge predominant, we can have these general measures and find the best treatment for those patients. And when they've got equal effect, we can have several manners of managing the patients. So now I want to give the voice to Dr. again to tell us some things about what to do when we plan the surgery. Thank you.